डॉक्टर सुखुजा, आपके यहाँ नए स्टूडेंट्स आ गए कुछ कि नहीं? अभी नहीं?
हाँ, yes, only yesterday we have one student per year. Only yesterday a young lady has joined.
Okay.
Her name is Dr. Sukhveer Kaur.
Okay.
So in fact I was also waiting कि कोई join करे. ये तो September से pending था last year.
Yeah. It's been pending.
So long, and I was worried कि seat खाली ना रह जाए. लेकिन कल ही join किया उसने.
Yeah, अभी I think first round is happened. I am not so sure that whether second or third round.
So this is second round going, sir.
Second round going now.
Second round.
Days? Okay, good.
Next week
we are live. Students, more than 35 members have joined, sir.
Okay.
Yeah, we can go ahead.
Yeah. So good evening, sir. Can we start?
Yes, please.
Hand over to Professor Sakhuja.
Please start.
So good evening, students and all the senior faculties, delegates for today's evening. We are very glad to go into our next session of Master Bedside Clinics in Nephrology. We are very happy to welcome you again for this third episode. As you are all aware, today's we would have the examiners who will be introduced by our course director. We are very happy to have our course director, Dr. Vinay Sakhuja, here today, who will be taking us towards this elite session. So I request Dr. Vinay Sakhuja to take the session forward from here. Over to you, sir.
Thank you very much, Mr. Raja, for the kind invitation to participate in this program, along with Professor Kher and Professor P.P. Varma. It's indeed a privilege to be with both of them, very eminent nephrologists. So I think we can now go ahead with the case presentation with the student from Dr. Kher Center.
Yes, Mayur, you can share your slides.
Yeah. Yes, sir.
Full size.
Yeah.
Yes, you can start.
Yeah, good evening to respected teachers and my colleagues. So first I'd like to thank Dr. Kher sir to giving me this opportunity to present this the case on this national platform. So with this, with the due permission of sir, I am starting my case. So he is a Mr. 50-year-old gentleman. He is a resident of Rewari. He is a shopkeeper by occupation. He had I like to start my history dated back in 2007 when he was 35 years of age. He presented with complaints of early satiety and abdominal fullness. At that time, there were he denies any history of flank pain, fever, hematuria. There were no history of any suggestion of lower urinary tract symptoms, and no history of any abdominal pain, nausea, vomiting, and no any history of yellowish discoloration of eyes or urine. So on direct questioning, he remembered that his blood pressure at that time was normal, and his blood investigation, he remembered that his other blood investigation were normal, and including the renal function. So on further evaluation, he was evaluated for this abdominal complaint, and he is incidentally detected to have bilateral enlarged kidneys with multiple cysts on ultrasound, and he is detected to have polycystic kidney disease. So he was then remained under follow of his local physician with regular monitoring of renal function and blood pressure. So with these he is with the touch with his physician on regular monitoring. 5 years after this, during these 5 years, he was asymptomatic and he was monitoring his blood pressure and renal function with his physician. So 5 years after this, in 2012, when during routine evaluation, he found to have first time raised blood pressure, which he used to remember was around 160 by 90 millimeter of mercury. So at that time, he also remembered that his creatinine was increased at that time, which he remembers to be around 1.8 milligram per deciliter. Earlier, it was 0.8 milligram per deciliter. Although he denies any history of any localizing signs or any acute cause any other symptoms. He was asymptomatic, and during routine evaluation, he found these complaint. He found this investigation. So at this point, he was first referred to nephrologist, and subsequently he was prescribed antihypertensive medication, the name of which he didn't remember, and he used to take 2 antihypertensive drugs to maintain his blood pressure. And he remembered that his blood pressure was around 120 by 120 to 130 millimeter of mercury. So then in 2008, he had his first urological event. He had complete fever with chills, and he admitted to the hospital. And he remembered that during this time, his renal worsened from around baseline of around 1.8 to 2 to 3.5 milligram per deciliter. And at that time, his NCCT abdomen was done, which showed evidence of cyst hemorrhage, and the diagnosis of cyst infection and hemorrhage was made. And he was managed with IV fluid, antibiotics, and bed rest. So after that, this first urological event, his serum creatine stabilized to around 2.5 milligram per deciliter, and he's continued with his antihypertensive medications and the other symptomatic management. So in 1 year down the line, he again had his second urological event in 2019. He had left flank pain and hematuria. During this time also, he had renal dysfunction, and he had again an episode of cyst hemorrhage, which was managed conservatively, and it resolves in about a week. But after that, his serum creatine was stabilized to around 3 milligram per deciliter.
Just one minute. Can I interrupt you for half a minute?
Yes.
You said in 2018, he presented with fever, hematuria, right flank pain, and there was cyst hemorrhage. What was the diagnosis of cyst infection based on?
Sir, actually, the diagnosis of cyst infection was based on the symptoms like fever, chills, and flank pain. And he didn't remember exactly, but he was told that there was some kind of urine culture was positive, and he was managed with IV antibiotics at that time.
Urine culture was positive.
Yeah.
So, so that's the point that I wanted to make. You said there is a cyst infection, but now you say the urine culture was positive. So is there no difference between these two situations?
Yes, sir, there is a difference. In case of cyst infection, there won't be a urine culture positivity, as it was not communicating with the collecting system. When it is communicating with the collecting system, then urine culture, usually in a cyst infection, that the urine culture is sterile.
Yeah, so therefore, that's the point I'm making. If the urine culture was positive, I would simply call it a urinary tract infection. I would not call it a cyst infection. And I'd like to also emphasize that urinary tract infections are far more common than cyst infections in ADPKD. Right?
Yes.
Cyst infections
Yes.
do occur, but they are rare as compared to urinary tract infection. So I don't think you should call it cyst infection. It's not proven at all. You have definitely a UTI.
Yes.
Is it clear that
Yes, sir. Yes, sir.
do not label it as a cyst infection? Cysts are not communicating with the pericardial system. So you are not expecting a culture positivity. As Professor Sakhuja told you, it's a UTI. He had fever, he had dysuria, he had flank pain. So it was a UTI which the patient had. Go ahead, we will start the questions once you finish your
No, I thought while we were here, it may be important to discuss this distinction between urine infection and a cyst infection. And Mayur, why do you think it is important to distinguish this? Is the treatment going to be somewhat different if it is a UTI or if it is a cyst infection? I thought this is the point which is being discussed, and we may take it out of the discussion right now.
Yes, sir. So there is a difference in the treatment protocol in accordance with the cyst infection and the urinary tract infection. Although in the cyst infection, it is as sir said, it is difficult to diagnose because of it is not communicating with the pelvic acid system, and the urine cultures are sterile. So it can be diagnosed based on if we are highly suspicious of cyst infection. So aspiration and then culture of that cyst fluid can be done, and according to that we can diagnose the cyst infection. So for cyst infection we have to give the longer therapy of antibiotic to around 4 to 6 weeks, which and the antibiotic of choice are those that penetrate the cyst. Usually we use trimethoprim, sulfamethoxazole, and the fluoroquinolones. The treatment for the cyst infection are longer as compared to the urinary tract infection.
You don't have to do cyst puncture in the beginning. If a patient is presenting with flank pain, you feel he has got fever, he has got tenderness, it's enough. If you have diagnosed clinically, you can start antibiotics. It is only if the infection, and you are right, it is a lipid-soluble antibiotic you need to start, whether it is quinolones,
can we mute everybody?
Can you switch off the mic?
You've lost 4 kilos, 4.4 kilos.
Can you mute everybody? Can you mute everybody?
Pressure is much better.
I think there are people who are in the clinic and seeing patients, I guess.
So it is only if the infection is not resolving, that will be the time you have to do any cyst puncture or isolate the bug. All right. Now, since you have already started here, how was he diagnosed as a case of polycystic kidney disease?
Sir, on the basis of ultrasound, he was told that he has enlarged kidney and bilateral multiple cysts were there in the kidneys.
So his age was 35 years when he went to the doctor. That is the time. So what is the diagnostic criteria for diagnosing ADPKD at the age of 35 years? That was his age.
Yes, sir. So the criteria that was given by Ravens, and again that modified by Pi, that is a modified Ravens and Pi criteria was there on basis on the ultrasound criteria. So that says between the age of 15 to 39, if there are
we are talking about this patient, 35, yeah.
Yes, so more than 3 cysts based on the ultrasound criteria and with a positive family history.
Okay. So if there is a positive, these criteria will be valid if there is a positive family.
If there is a positive family history.
No, we have not come to the history. Suppose there is no positive family history. Then how many cysts?
Sir, if there is no positive family history based on the ultrasound, there are more than 10 cysts on the 10 or more cysts.
No. Whose criteria is this 10 cysts? The Ravine criteria is again 5 cysts. All right. If the family history is not there, then if there are minimum 5 cysts total, you can diagnose. All right. Please go ahead.
Then on follow-up period, he had lost to follow-up for next 2 years. He had a gradual progression of serum creatinine to 3.5 milligram per deciliter in February 2021. He was non-compliant to his blood pressure medication. No further episode of flank pain, fever, hematuria, and abdominal pain based on the history. And he remembers that his serum creatinine was around 4.6 milligram per deciliter in December 2021. So, and now he currently presented to us with a complaint of decreased appetite, persistent nausea and vomiting, around 1 to 2 episodes per day, non-projectile, not associated with headache or since 1 month. With this chief complaint, he presented to us. So at there is no history of any fever, abdominal pain or loose motion at this time. No history of any yellowish discoloration of eyes or urine. No history of any lower urinary tract symptom, and no history of any decreased urine output or pedal edema, and no history of any NSAIDs or alternative medications. So with this complaint, he presented to us. So his personal history include his bowel and bladder are normal. His appetite is decreased, and he had smoking addiction, 10 packs per year. His family history showed that he had his mother died 15 years back at the age of 65. She had some kidney problem which was undiagnosed. They remember only it as she had some form of kidney problem, and she also died of stroke, also cerebrovascular accident at the age of 65 years. This was our index patient aged 50 years, and his brother, he was also screened for about, he is 54 years old, hypertensive, and he also has a cyst diagnosed to have ADPKD based on the ultrasound criteria. And his younger sister was also affected with the same. And he had two sons, 30 years old and 24 years old. His elder son has been screened and he had cyst with no hypertension at present. And his other son did not undergo screening at this point of time. And his brothers and sisters, sons and daughters are not screened at this point of time. So, my provisional diagnosis based on this history, so it looks like a chronic kidney disease progression with etiological diagnosis based on the family history. It is autosomal dominant polycystic kidney disease with a comorbidity being hypertensive.
Now, Mayur, can you summarize it, what you have said?
Sir, he's a 50-year-old male, diagnosed ADPKD, autosomal dominant polycystic kidney disease 15 years back. Started with normal renal function, had hypertension 5 years down the line. Renal dysfunction started at around 40 years. And with two urological event happened with a cyst hemorrhage and one urinary tract infection. And later had a progress to end-stage renal disease at this point of time, and he was now presented with uremic symptoms.
You tell me, what is his EGFR at this stage?
Sir, the investigation at this point of time, he presented to us with a serum creatinine around 8.8.
What is the GFR? Maybe around 4 or 5. Now you have to tell us first, is he a rapid progressor? Is it a slow progressor? You have given a history. This is a patient who is diagnosed ADPKD at the age of 35 years. Over the next 15 years now, he has progressed to end-stage kidney failure. So he has taken 15 years. And this 15 years is punctured by a couple of episodes of hematuria. All right. You are not aware whether it's a cyst, hemorrhage, or what is. He had punctured with hematuria episodes. Now, I want to know from you, you told us that his creatinine in 2012 was 1.8 milligram, isn't it? Now, is he a rapid progressor? Is he a slow progressor? What is his type?
And looking at his progress, loss of GFR is considered, he looks like to be a rapid progressor because he landed in an end-stage renal disease at age of 50 years. That is one of the reaching ESRD at 50 years is considered to be a rapid progressor. So he is looking at rapid progressor.
Generally, these patients follow a similar history as parents.
Yes, sir.
You gave a history. His mother is possibly had a renal disease. You do not know what. And but he possibly had a stroke. What are you interpreting? What mother had?
Sir, looking at the family tree, the mother looks like to have some form of polycystic kidney disease only, and she died of any stroke that can be an extra-renal manifestation of polycystic kidney disease.
How common is this?
Sir, extra-renal,
No, we are talking about her mother. You said you are not aware she had some renal problem, but she died of stroke. We are trying to correlate that possibly she died because of ADPKD. How common is to have stroke in a patient with ADPKD?
So, sir, if we look at the like asymptomatic intracranial aneurysms are around 8 to 10% in case of ADPKD patient. If we consider the both include morbidity and mortality associated with the stroke and ADPKD, it is around 30%.
No, is the bleeding or the rupture of aneurysm, as you said, aneurysm may be there in 5 to 9% of patients. Agree, there can be there. Now, are they more likely to rupture than the common population?
They actually they are more likely to not more. They are same in case of risk of rupture. They are sorry, sir. They are more likely to rupture than the general population.
The risk of rupture is 5 times higher than the general population. You should be aware of that. And we will come gradually that why he should be screened or not. But you said that he is probably a rapid progressor. How do you define a rapid progressor?
Sir, so the rapid progressor where we can use the Mayo Clinic classification for defining the rapid progressor, which is based on the total kidney volume adjusted for age and height. So we can use that classification to classify the patient as rapid progressor. So based on that classification, it was the typical ADPKD patients were classified in the 5 classes, that is 1A to 1E. Based on the total kidney volume measurement, and that is the one criteria that we can follow for.
How much?
Mayur, you have a slide for that? If you have a slide, show that.
Yes, sir.
Now that the question has come, it's good to show that.
Yes, sir. So this was the classification that was used. That is the for Mayo Clinic classification that uses the total kidney volume adjusted for age and height. So it classifies the into 5 criteria to 1A to 1E, and the 1A and 1B are considered.
What does 1A means? How much is the cyst growth?
Less than 1.5% per year.
1B?
1.5 to 3%, 3 to 4.5% in case of.
If it is more than 3% per year, it becomes 1C and above. That means it is a rapid progressor. Now, mind you, the Mayo Clinic is measuring total kidney volume, height adjusted total kidney volume. All right, but we are talking of GFR. Are they correlated?
But they have not correlated with the Mayo Clinic classification and not correlated with the GFR. The European Renal Association has given the classification for rapid progressor based on ESGFR index for age.
No, keep in mind even that CRISP classification, CRISP criteria, because when you see the total kidney volume, it is eventually correlated with a drop in GFR. That is important. That is why in the trials, total kidney volume is taken. The total kidney volume, what you measure today it may not be correlating with the GFR, but eventually it is correlated with GFR. Now, suppose the patient, whatever the criteria may be. Now, if a person you find he is 3, let's say 1E. Now, what is his chances of going into end-stage kidney failure? Or 1D? Let's say over next 10 years.
Like if 1E or 1D is there over the next 10 years, he will be a 30%.
Maybe more than that, because he is a rapid progressor. If you are talking about D or E, the chances of his hitting end-stage kidney failure over the next 10 years is pretty high, over 50%. All right. Now, go ahead. Now, you said now, again, go back. You gave a history that it is punctured by cyst by hematuria. What does hematuria imply? Before you go ahead, can you give us a definition of hematuria? What is hematuria?
More than 3 RBCs per high power field.
more than 3 to 5 RBC per high power field on 2 occasions. Not only one, on 2 occasions. If a person is having hematuria, ADPKD patient, what does it mean?
So it is communicating. So there are differential. It can be a cyst infection. It can be associated with stones, or in rare cases, it can be associated with malignancy.
Yeah, so that's good. That's correct, you said. Keep in mind, cyst hemorrhage is a commonest thing. Cyst hemorrhage is number one, logically. And subsequently, after that, as you said, it can be an infection, it can be a stone, and in rare occasion, it can be malignancy also. So he had possibly what hematuria you are having, possibly he had cyst hemorrhage on couple of occasions. All right, please go ahead. Then what happened? Now let's come to his examination.
He is
anything you will like him to answer. He has progressed. He has said that possibly he was diagnosed ADPKD at the age of 35, and he had punctured course with diagnosed hypertension, diagnosed creatinine, was gradually progressing, and he has progressed to end-stage kidney failure. Now, if suppose at the age of 35, I wanted to predict his outcome, can I? Can I predict his outcome? Parents want to know. He is a child. He is not a child. He is an adult of 35. Please tell us what will happen to him.
We can predict his outcome based on his, if we have a measurement of total kidney volume at baseline is available. So based on that and using the criteria as we have discussed, we can predict his outcome, whether he will be how he will behave in future.
So one you said is the total kidney volume. If the total kidney volume is high, you take it 700 or 750 ml. So logically, he may be a rapid progressor. Next, this is one criteria. Number two, what about the kidney length?
More than 16.5 centimeter.
If the length is more, you can predict that possibly he is a rapid progressor. Now, go ahead. What about the development of hypertension?
So the hypertension is considered to be one of the risk factor for rapid progression. So if the hypertension develops at early age, he is considered to be a rapid it is one of the criteria to identify the rapid progressor.
But mind you, that criteria, what we call pro-PKD score, is valid if prior to 35 years of age, he develops hypertension or any of these urological complications. This patient has developed all this. He is diagnosed hypertension in 2012, you said, at the age of 40 years. So he is not fitting into that. He developed hematuria after the age of 40 years. Initial 35 years, he did not have. So possibly at that point of time, except for a family history and a male sex give him a risk. But he is not hypertensive. He doesn't have any urological problem. Only we do not know the family history, that what type of mutation he has. Now we can say if he is going into end-stage kidney failure at the age of 50 years, possibly we can say that he fits more into PKD type 1. But otherwise, at that point of time, they were not very bad prognostic markers in it. Barring male sex, that's all. ADPKD diagnosed 35, we did not know. And moreover, his mother, you said at the age of 65, she was alive. She was kicking well. Only she had stroke. That means the time course of this patient is not following the family. His mother was pretty well at the age of 60. Okay.
Yeah, I think can I make a point here? And I think although what you said, General Varma, that most of the time, many of these patients might follow a family pattern of progression of kidney disease, they might be able to, you might be able to predict how they are going to progress as such, but there may be on their path towards progression. There could be other factors which could be causing deterioration in kidney function. And as you said that severity of hypertension, degree of proteinuria which may be present, which may come up in some of these patients, may not be present in the early stages when you may have done the predictive modeling, but later on some of these, and then recurrent urinary tract infection, stone development in these might, and then interstitial, drug-induced interstitial nephritis to treat some of these conditions which might happen. They might produce a more rapid deterioration in some of these patients, and others who probably may not develop these complications may follow a pattern which may be slower. Although, would that be okay, General Varma? I think there will be.
Absolutely.
Yeah,
those are predictor markers,
yeah.
but the patient is not following what is given in the book. Every patient is different. If he's as he rightly said, he's an uncontrolled hypertension, and we don't know. He has not come to the lab how much proteinuria he is having.
Yes.
So let's come to the lab the examination.
He is conscious, oriented to time, place, and person. His weight is 71 kg, height is 172 centimeter. His BMI was around 24 kg per meter square. His pulse was around 78 per minute, regular, normal force, volume, and tension. No radioradial and radiofemoral delay, and all peripheral pulses are well felt. His blood pressure was in the right supine position was around 160 by 90 millimeter of mercury. And in left arm, it was 154 by 84 millimeter of mercury. In lower limb, it was 172 by 84 millimeter of mercury. He had mild pallor, mild pedal edema was there, no icterus, cyanosis, and clubbing. And there is a presence of grade 2 changes of hypertensive retinopathy on fundus examination. On urine examination, he had protein 2+. There were absent of glucose and there were no RBCs. And UPCR was around 1.89 gram. His systemic examination, his CNS examination is he's conscious oriented. There is no any focal neurological deficit. His respiratory examination showed no adventitious sounds, and his air entries was equal on both the sides. His cardiovascular system examination showed evidence of left ventricular hypertrophy in the form of downwards and outwards of shifting of apex beat. And his per-abdominal examination showed the umbilicus, on inspection, the umbilicus is inverted. There are no scars, sinuses, dilated veins, and hernial sites are normal. There appears to be a flank fullness. And on palpation, the bilateral kidneys are palpable, and there is no any other organomegaly was there. So, so this was a general examination and systemic.
So what was the blood pressure you said?
Sir, on presentation, it was 160 by 90 millimeter of mercury. 160
by 90 millimeter. Okay. And nothing else except ballotable kidneys.
Kidneys.
And the blood pressure was 160 by 90.
Yes.
And what you said importantly, the UPCR was 1.89 grams. That's pretty high.
Yes.
Pretty high.
Yes.
Almost 2 gram proteinuria. Go ahead. Investigation.
His investigation showed his complete blood count showed hemoglobin of 11, counts were 6.37, and platelet was around 150 lakhs. So he had anemia. His creatine one presentation was 8.8. He had normal electrolytes, bicarbonate was 19. His viral markers were negative. His CKD-MBD workup showed high PTH with high phosphorus around 450 and 7.7. His albumin was 4 gram. He had underwent ultrasound also. He had bilateral enlarged kidneys of measuring around 16 centimeter with showing multiple liver and kidney cysts. And his echocardiography showed no regional wall motion abnormality, and there is evidence of concentric LVH with ejection fraction around 50%.
Okay. Now, I think there are questions coming from experts, faculty also. Coming one by one to this investigation, what did you expect in 2D echo? You are finding there's no regional wall motion abnormality, concentric LVH, you expected that. Anything else you expect in echo?
Sir, in around 25 to 30% of patients with ADPKD, there are extra-renal manifestation of cardiac point of view. There is the most common being mitral valve prolapse and the aortic regurgitations. And sometimes they have evidence of
mitral valve prolapse or aortic regurgitation also.
Yes.
What about the ultrasound? You said there are cysts in the kidneys, bilateral, and the multiple liver and kidney cysts. Where all you can expect cyst, and let's say theoretical, what percentage?
In case of ADPKD, the liver cysts are common in around 70 to 80% of patients, and in other organs they can found in a pancreatic ductules, which are around 8 to 10%. Also in the case of the seminal vesicles, which is around 40%, and in case of arachnoid membrane, which is around 8 to 10%.
Okay. So that you mentioned that the cyst, extra-renal manifestation, cardiac you mentioned that abdominal problem, the cyst can be there. Any other extra-renal manifestation you would like to mention?
Sir, intracranial aneurysm, asymptomatic intracranial aneurysm, which is around 8 to 10%, and the colonic diverticulosis and diverticulitis, which is around 20%.
My other things like hernias and diverticulosis, what you mentioned. Now,
yeah, just one point regarding the liver cyst. He gave a figure of 70 to 80%.
Sir,
Is this the figure across the board?
Yes, sir. The literature does mention that
sexual predilection.
Eventually 80% of patients will develop liver cysts.
Yeah, but he didn't talk about any sexual predilection. This is well known.
In females, it was females.
That females with ADPKD have a much higher rate of developing liver cysts. They tend to be much larger in females, right? And it also depends on the age group of which you are talking. The figure of 70 to 80% may not apply to all age groups. The older the patient, the more likely you are to find liver cysts. So I think you need to qualify that statement. It is not across the board that you will have 70 to 80% of ADPKD patients having hepatic cysts.
So you have to, like Professor Sakhuja mentioned, qualify, as we said, eventually. So by and large, in an advancing age, more common in females, you can have these cysts. All right. Now, coming to, let's see this patient. Do we have anything after this?
Yes, sir. As he presented, yes, sir. We have also screened him for the aneurysm because he had his mother had history of CVA, and he presented to the advanced failure. So angio was also done with short, small saccular aneurysm in the anterior communicating artery, which is around 4 mm.
Now you have to now tell us that is screening of aneurysm required?
So the screening is recommended, sir, in case of if there is a family history of intracranial aneurysm is there, or in case there is a past history of any aneurysm, in case of high risk profession involved, that is like air pilot, bus drivers. In that case, the screening is recommended.
No, say again. One, you said if there is a family history or a past history of bleed. So that is one risk factor. Now, because now will you screen everybody? Suppose a high risk population, you are saying a pilot. Will every pilot you will screen for aneurysm?
No, if there is a strong family history associated with that part, then we should screen that.
All right. So to those people, as you said, that if there is a family history, or if a person is symptomatic, maybe with headache, with maybe cranial nerve palsy, or whatever, that gives a hint that possibly we should screen. And when should you screen these people?
Sir, in around the mean age of the rupture was around 40 years. So we can screen them in around 4 to 5 decades of their life.
So logically, you have to screen if the symptoms are there. Otherwise, if a person is going ahead with a surgery or something, there's a risk. A person has got uncontrolled hypertension. A person is going to be using anticoagulants. So if such are the person is going to go for transplant, if there are one of these criteria risk factor, that is the time you should screen for aneurysm. Now this patient has got aneurysm. Let's see, you showed there is an aneurysm. Now if the aneurysm is there, should he be operated?
So, sir, there are it depends on the site size and the look and usually the family history. There are studies that showed if the size of the aneurysm is less than 6 mm, so we can manage that conservatively. And if the more than associated with the positive family history, and if the size is more than 6 mm, so we can offer a surgery before going for a transplant. And also there is a study that showed that the anterior circulation aneurysm were less likely to rupture as compared to the posterior circulation. So it depends on site size and the prior history.
What was the size of this patient? 3 millimeter.
3 millimeter.
So will you like to leave it alone?
Sir, actually, this patient mother had died of CVA, and also in case of there are literature that said if there is an intracranial aneurysm associated with the family history of subarachnoid hemorrhage, then there will be a more chances of rupture in this patient also. So in this patient, he can be considered for coiling or clipping before transplant.
I think I am inclined to think on your line that since there is a positive history, family history, and we also know that this patient is going to undergo possibly whatever, I don't know whether he has got a transplant or not. So if that is there, I think it will be prudent to intervene. What do you say, Professor Kher, in that case?
No, I would agree. This was discussed in our meeting as such also, that this is the patient who is going to go for transplant. Since he is going for transplant, so prior to surgery, as you said, it would be prudent with the background that his mother died of a cerebrovascular accident and seems probably to be the person who probably also had polycystic kidney disease. So I would think that I would tend to, although the size may not necessarily be big enough, but in a patient who has family history of a stroke with a death, I would be tempted to intervene in this patient and maybe use a coil or something to block this.
I think Vinay will also agree.
I would just like to inject a little bit of doubt there. See, we know that the mother had a CVA, but we have no idea what kind of CVA. We have no confirmation. We don't even have a CT scan to prove that this was a subarachnoid bleed. It might have been a thrombotic stroke, so we don't know, or an intracerebral bleed. So there is a certain
That's agreed. That is agreed. It is only that you are sort of putting these dots. The dots are not clear at all. But but the history fits in, obviously. I agree that we don't know whether she had polycystic kidney disease also or not. Because we don't have an ultrasound or anything. But considering that there are 3 other family members who have polycystic kidney disease, and the mother, probably father, continued to live till about 73 years, no kidney disease. Mother had a kidney disease and also had stroke. So one would tend to believe that that's likely. But yes, I agree. As a purist, yes, we don't know whether that is true or not.
Yeah, we don't know for sure. Yes.
But in this patient with this kind of a background history, I would probably, if I were to discuss with him, I would offer him that this is what it is. The chances are much higher for you to have a bleed. And with an intracranial bleed, before you go for transplant, we could give you this, and he along with could decide whether he wants to go ahead with the surgery or maybe take a risk that he doesn't want to do it and accept the risk.
Okay, Mayur, go ahead. So this is the opinion that possibly we should. Okay, go ahead.
So, sir, he presented with these uremic symptoms and advanced renal failure. So, he's initiated dialysis at our center, and during hospital stay, he underwent a 3 session of hemodialysis through right IGV non-tunnel agitated.
Once he's starting on dialysis, he's going to be an heparin also. So that also adds a risk of bleed. Okay.
Yes, sir. And now he is being discharged, and he is planned and work for renal transplant.
Now, who is the donor?
So, sir, from the wife, we are considering the prospective donor.
Okay, okay. Now, let's say in his case, what workup you want prior to transplant? Let us say if the wife, not wife, his brother is how? What is his age?
His brother is, sir, having the detected cyst in the kidneys. His age is 54.
And he has got how many brothers?
He had one brother and one sister. Both are having the cyst.
Suppose there is a 30-year or 35-year-old brother, and he wants to donate. What will be your take?
If his brother is around 30 years of age, then he should be thoroughly investigated to rule out the autosomal polycystic kidney disease in the form of first ultrasound. But ultrasound in the age group of less than 30 years is insensitive in detecting the cyst. So he should undergo the MRI or the CT to have detection of cyst. If MRI and CT are equivocal, showing equivocal cyst, then he should undergo.
What is the MRI criteria?
Sir,
now you have done an ultrasound. On ultrasound, as you said, if suppose the brother's age is 35, you expected at least how many? 2 cysts or 3 minutes?
Less than 5 cysts. They exclude.
I'm not finding cysts. So what should I do? MRI?
Yes, sir.
Now, on MRI, how many cysts should be there?
So in case of age group of 16 to 40, more than 10 cysts. If they're
it's very nice that you are giving a correct figure. That keep in mind, we do not have a solid laid down criteria. Can we mute? We do not have solid laid down criteria. I think what is projecting. Hello. Can we? Now, what you are quoting, this is a TRISP study. Now, TRISP study, it is from Toronto, where they have seen almost 110 patients, and they have taken 45 controls also. Now, these patients are proven ADPKD by mutational analysis, and then they have followed. And what figure you are saying is from that study. So it is not a laid down criteria, but this is a study data that from 16 to 40, if you are finding more than 10 cysts, in ADPKD, invariably, there will be more than 20 cysts. You will find more than 10 cysts in each one. So if you are finding more than 10, the cutoff has taken, the positive predictive value is 100%. And if in these patients you are getting less than 5 cysts, possibly you can exclude that it is not there. But the confusion can come if, let's say, there are 9 cysts or there are 8 cysts. You cannot say there are less than 5 cysts, so there is no ADPKD. More than 10 is ADPKD. Now he is finding in between. So that is the confusion, that if a person doesn't have, like in your case, there is no definite family history. Now, mother, you don't know mother or father, definite family history of ADPKD. And if you find there is a doubt of this, in those cases, possibly a mutational analysis will be required. So we are not routinely recommending it because of expense and time consuming. But if you are stuck in such a situation, suppose a 25-year-old child wants to give, I mean, those are the situations where you can do a mutational analysis. Do you have any slide for mutational analysis?
So, now, Mayur, I would also want to add along with this, which will help you, is when would you think would genetic testing be necessary or required?
So the genetic testing, that there are certain condition in which genetic testing is helpful, which include if there is no apparent family history, as in this case, and if we have to disease exclusion at a very young age of less than 30 years, in case of early and severe presentation, in case of during early childhood, due to the biallelic presentation or due to the mutation of both the heterozygous PKD1 mutation is there, in that case there is early severe presentation. In that case, genetic testing is recommended. In case there is a discrepancy in the case of imaging class and the renal decline in renal function, and if there is a syndromic form of polycystic kidney disease is evolved, and if there are atypical imaging pattern on ultrasound or MRI which are unilateral, like unilateral segmental lobe-sided, these imaging require the genetic testing to confirm the diagnosis. And in case of now the newer in case of prenatal and pre-implantation genetic diagnosis. So these are the indication of genetic testing.
Now coming, Mayuresh, to little therapeutics. We all are aware about the tolvaptan. And can you just tell us when was it approved by FDA?
In April 2018.
Very good. Thank you. Very good. This is 24th April 2018. It got approval. Now, if you are the person who was treating them, and this was the presentation of this patient, will you like to treat him?
Yes, at the when he was detected to have the hypertension and the renal dysfunction at around the age of 40 years, so at that time we can intervene with the disease modifying agent, considering the presentation, and at that time I like to treat him with the disease modifying agent.
So first give us criteria when you will like to treat a person with tolvaptan.
So there are the in case of so sir, in case of rapid progression, like if age is less than 55 years,
give the definition. What is rapid progression?
If sir, age is reaching the end stage kidney disease by the age of 62 years.
No. That is, you are giving, he has come to you at 35 or 40, whatever age. You have to take a call, should I start tolvaptan or not? On what criteria you will start? 1, 2, 3, 4, 5 criteria.
Sir, based on the Mayo Clinic classification, it fits into 1C, 1C-D-E criteria. Then
number 1, if he fits into 1C to E criteria. So that is a rapid progression. That is cyst volume increase more than 3% per year. If you have got a background data that in the last 5 years he has grown 2.5% or 15%, fine. If you don't have, this is one criteria. So in the Mayo classification chart, you can put his age, you can put the cyst volume, and you can calculate on that with which class he will fit into. If he fits into 1C to 1D, 1E, he is number 1, that is 2. Number 2.
Sir, in case of if we have genetic analysis available, pro-PKD score more than 6.
So if the pro-PKD score is...
Do you have a slide for this?
Yeah.
If you have it, put that slide, that would help you.
That is more than 6.
Yes,
if
sir.
the pro-PKD score is more than 6, he comes into that. Number 3. If you find the kidney size is more than 16.5 centimeters,
yes,
straight on day 1, you find the kidney is big, this is again a criteria that you can go ahead for treating that.
Yes.
All right. So that means if you know what is the speed of progression, if you don't know speed of progression, just put the MRI kidney volume and age into the Mayo Clinic criteria. Or if the kidney length is more than 16.5, he will fit into treatment. All right. Now, what treatment you would have given to him?
Sir, so the control of hypertension, basically first by using the inhibitors and so there are so there are two. So this evidence is based on the HALT PKD study. That was a study A and study B, which showed the blood pressure control in around 110/75 in case of age group of 18 to 50 years is recommended for patient with ADPKD, with the first line being AC inhibitors and ARBs.
So that is what you're saying. HALT PKD trial 1 and 2, they clearly showed that if the BP is kept 110/60 or 70, yes, it is better than keeping higher BP. And the second trial showed that AS/R is adequate. You don't have to combine these. So that is a trial. So you have to keep BP at a lower end. I think you have put the slide. I was not aware you are having a slide. So both these are same points what they are seeing. Keep the BP of, this is 99 to 110. That is the BP you have to contain if you want to slow the progression. So that is one. So you said number one, you will control blood pressure with ASR, and you can have second any drug. So that is one. Number two.
Then we can advise him the low sodium intake, which is around less than 2 grams per day, and liberal fluid intake around 3 liters per day to maintain the urine osmolarity around less than 280.
We will come to this point again, what you are saying. And
this is
what is this? Whose study is this you are talking about? Urine osmolality. How much urine osmolality should be there?
This was the study in the reprise and the
you are not audible, but keep in mind, if you read the supplementary analysis of Tempo 3:4 trial, so that is the point. They wanted to lower the osmolality. Now, incidentally, when they started in the trial, the osmolality was around 500 plus. Now, 50% of these patients had achieved a osmolality less than 200. Now, another 25% was around 200 to 300. That was the range. So, that subsequent analysis was done, and the Canada is following this. That is called Canada Health. So Canada Health follows that there is no point if the benefit is obtained if the osmolality is less than 250. So that by going down below 250, you may not get additional advantage. That is the Canadian outlook at the moment. People will have different opinion because in this Tempo trial, a reprise trial, a high dose of 120 milligram was given. 90 in the morning, 30 in the evening. Tolvaptan. Now, that's all right. Over 60 to 70% of the patient were able to tolerate this. Another 20%, 25% were taking 90, another 15% were taking 60 milligram, but bulk were taking 120 milligram. The question can be either give as much tolvaptan as possible. Other opinion can be that try to control the osmolality. So possibly I may be of the second school of thought with the Canadian Health that maybe as long as if I am able to maintain a osmolality below 250, I'm happy. On this point, I will not give my definite opinion. I'll ask opinion of Dr. Kher also, Dr. Sakhuja also. Professor Sakhuja, sir.
I think there is an important point that you have made, that if you can maintain the osmolality, the urine osmolality below 280, as Dr. Mayur said, but you mentioned below 250.
That is the Canadian analysis.
Okay.
They found that there is no benefit getting accrued by increasing the osmolality below 250.
Going below 250.
Yeah.
Okay. So 250 is the target cutoff, not 280.
That is what the Canadian believe, but that's why I said I'm not giving my opinion.
Because because what I also read was a target of less than 280. That's why I was asking this question. This is a review article in Kidney Medicine published in 2020. So that is the cutoff that I had read about, that less than 280, which Dr.
Serum osmolality.
Yeah.
Professor Kher, sir, your viewpoint on that.
Yeah, no, I am not so sure that there is good evidence for this. The trial data, obviously, some patients achieved less than 200, others achieved between 200 to 300. And I don't think there were sufficient numbers to sort of clarify whether the progression was any better in those who had achieved lower osmolality. So this point will remain. The question is, they were able to give higher dosages. Unfortunately, in many of our patients, our tolerance to tolvaptan dosages beyond 60 milligram, cost being an important determinant also, I think that may add to the adverse effects. If you suggest to increase the dosages and the cost increases, obviously, I think the adverse effects also increase. And so therefore many patients are not able to take more than, I have very few patients who have reached 90 milligrams or so. Majority are on 60 milligrams. Yeah. And the osmolalities that you achieve are somewhere around 280. Some of them don't go less than 300. But yes, majority of these patients with the amount of water intake that they take, which is liberal, are able to get down to 280 and less.
So that is an important point, Mayur, you have to keep in mind.
One question. Just one question. This target osmolality, how would you do the measurement? Would you do repeated measurements throughout the day? Or would you do just one or two?
Recommendation is, sir, that early morning, first morning sample, that is the best, that you do a osmolality in that. And in my patient, as Professor Kher is mentioning, I have given to one patient 45, otherwise the general range is 30 to 45 milligrams tolvaptan. And every visit, I tell them to bring the osmolality. They all bring the osmolality. And based on if it is going above the serum osmolality, as you said, 280, we are increasing the dose. But that is, as I said, there is no guideline available to that. This is what is my practice. Dr. Kher might say more dose should be given because the trial has given up to 120 milligrams. So we don't have a definite answer to that. So but tolerance and cost is another criteria. So one has to weigh what is to be done. Now, you again said
one more question. What percentage of patients with typical ADPKD will ultimately be considered suitable for a trial of tolvaptan? Roughly what percentage?
As I said, sir, roughly I will not be able to give a correct figure, but I think around 40 to 50% fall in that. I'm not quoting a correct data. There is no written this thing that out of so many. But as a experience wise, we find around 40-50% of patients who are rapid progressors, because we are measuring the volume by MRI. And keep in mind that initial studies, sir, use the technique of stereology to measure the cyst volume. But stereology was taking a lot of time, 45 minutes per patient. Then eventually they started doing with ellipsoid method.
Ellipsoid, yes.
Ellipsoid method, it takes only 5 minutes and it is almost equivalent. There is a difference of 5 to 10%, but almost equivalent. So the recommended method is ellipsoid method. So that is the method being practiced. If we find that the cyst volume combined is more than 600, that is one criteria. We again take if the kidney volume, some patient come with a huge kidney, more than 16.5, that then we are trying to put them on drug medication. Now, second question which came in between was water, that liberal water. The question will be how much water should be taken? And many people feel that water is a poor man's tolvaptan. Is it a true? Mayuresh, your comment.
Sir, so there are earlier studies that was done around with a fluid of around 3 liters per day, and they have shown there are some conflicting studies. There's some studies told the benefit of about 3 liter intake with maintaining urine osmolality of less than 280 helps in suppressing the vasopressin and then leading to halting the process of cystogenesis. So and there are some studies which showed the opposite result. So there are studies with the 3 liter.
The question is much more than that. The recommendation is even higher than that, 4 or 5 liters, and you have to take throughout 24 hours, because it is not possible then when you sleep at night that it is not possible to adhere to that regularity. So whatever trials are there, another risk is of hyponatremia once you are taking so much of water also. So at the moment, there is no trial which has compared tolvaptan with free water, and there's no trial with free water, only studies. So at the moment, it cannot be recommended that one should rely only on free water, take 4, 5, 6 liters. Yes, it is recommended that you should take free water, liberal, which is giving a benefit. But keep in mind 2 things. Younger the patient, higher the GFR, he is going to achieve low osmolality. If the person is older, kidney is older, GFR is less, it will not go down to osmolality, will not go down. So this is possible in younger people who achieve low osmolality. So that is one. Now, second question I will like to ask you, Mayur, that a person comes, you have started him on tolvaptan, and he says, Baba, I am passing 8 liters, 7 liters of urine. I am fed up. I cannot pass this much of urine. My evening, night, everything is spoiled. Can we benefit him by any means?
So, sir, we should advise him to take the maintain the hydration because of these aquaresis related side effects associated with the tolvaptan. So
go ahead. You are not audible.
Hello.
Yeah.
Yes, sir. To prevent these aquaresis related side effects, we advise the patient to take the adequate amount of fluid along with the tolvaptan.
Okay, that is one. And keep in also mind, there is some studies which are not very large studies. People are combining some diuretic, thiazide, a small amount of thiazide. One of the trial initially took 12.5 and then went to 25. The logic is that thiazide is acting on DCT. It is stopping sodium potassium chloride. So by stopping the sodium absorption is not occurring. When the sodium absorption is not occurring, there is increased urine output, and eventually there is a contraction of extracellular volume. So this contracted extracellular volume causes more sodium absorption from the PCT. So therefore, the more sodium absorption, more water absorption, so less goes down. There is no effect on the GFR change. There is no effect on that tolvaptan efficacy. So early studies are suggesting that in such a patient where urine frequency is causing problem, one can try that. And there is also a trials which are showing that possibly metformin also may help in this area. So just keep in mind there are new trials coming in this direction that thiazide and metformin can reduce the urine output by almost 30 to 40%, which is beneficial in patients who are fed up of increased urination. Now, coming to Professor Kher, you are commenting here now.
I think I also read this study on the thiazides related to trying to reduce by producing basically intravascular volume depletion and the secondary effects in the kidney, and therefore ultimately reducing the urine output and polyuria that is associated with tolvaptan. So I think that's probably maybe in consideration in occasional patients where that happens, but I think that's quite well. Now, I think the question on tolvaptan would be also, what are the adverse effects that one is concerned about?
I was coming to that. Very important, sir.
So, what are the adverse effects of tolvaptan?
So, sir, there are aquaresis related side adverse related like increased thirst, polyuria, increased noxuria, and urinary frequency. And also there are also showing the liver abnormalities, showing transaminitis associated with the tolvaptan. So, and increase in uric acid.
Okay. Yeah, liver dysfunction is something that one always needs to be concerned about, and if there is enzyme elevations, then one might have to decrease the dosages, and sometimes one might have to discontinue the therapy in these patients. So, so that's something which is important. Otherwise, and that might happen in about 5 to 10% of patients. You might see adverse effects, and discontinuation may occur in about 2 to 3% of patients.
And keep in mind these, that is why monthly LFT check is required.
Yes.
And most of these AST, ALT elevation usually occur between 10, 12 week to 40th week. And generally after that, it doesn't occur somehow. So one has to be vigilant during this period. So, Professor Kher, any other point?
I think that's as far as the tolvaptan is concerned. I think this is it's much cheaper in our country, but still much more expensive for majority of our patients because the dosages required are much higher. Although I don't know whether 45 milligrams and 60 milligrams, which most of our patients are taking, whether that is going to produce an effect in prolongation. One would need an Indian study to show that, because so far the Reprise trial did suggest that it's effective at 90 to 120 ml. Mayur, what was the kind of an absolute increase in the sort of decline in the GFR which happened with tolvaptan in control group and those with the drug?
It's a 5 to 10% decline in GFR was there with the initiation of tolvaptan.
Okay. No, what was the greater benefit that occurred? What was the absolute sort of difference in the decline in GFR between the tolvaptan group and the...
with the extrapolation result of Tempo and Reprise trial, this has shown this was shown as in this study from the extrapolation data that showed if the tolvaptan has been started with the eGFR of around 90, then with the requirement of renal replacement therapy or reaching the end stage renal disease, we can add up to 7.3 years benefit in case of tolvaptan group, if it is started at the eGFR of 90, similarly at the eGFR of around 16 can add up to 4.4 years, and around less GFR like 30 and 15, it can add 2.9 and 1.5 years. And similar results were shown in the based on the reprise trial also. With the eGFR around 60, it can add up to 6.8 year till reaching the ESRD. So on an average, if we consider both the trials, the tolvaptan has a prevention of about 1 ml per year.
Yeah, that is important. You have to mention that whether you are talking about tolvaptan, the tempo trial or reprise trial, that at least you are saving, if the fall otherwise is almost 3 ml per year, possibly you are able to make it 1.82 ml. So you are checking it to almost 35 to 45%. Cyst volume, you can check up to 45 to 50%. But GFR or the creatinine, you are checking it. GFR drop, you are checking it by 1, and your chart, which is reflecting, you are gaining many years, provided you are starting much, though benefit is there, like reprise trial at any stage. You can start at GFR 25, but earlier you start, better it is. You would have better gain. Professor Sakhuja, sir, any comment now?
Not in relation to tolvaptan. Just a general question to Dr. Mayur. What percentage of all patients with ADPKD will progress to CKD5 and dialysis?
So it was around 50%.
50%. So you mean half will remain off dialysis? I don't know. My impression was that that's around 70%. The others can also give their comments. And the other question is, what is the median age at which these patients get started on dialysis?
Sir, if we consider depending on if we consider PKD1 mutation, there is the ESRD at around 58 years, and with PKD2 mutation around 79 years.
Yeah, so around the median age is 58 years, as you said. So somewhere in the second half of the 5th decade, this is the time when PKD1 patients will go on to dialysis or require transplant. That is one. The other thing, how many abnormal genes have been identified in ADPKD?
So there are the classical being the PKD1 and PKD2, which PKD1 in around 85% of patients, 78 to 80%. In 15% of patients, there is PKD2 mutations, and other being the GNAP gene and DNA JB11 gene. And the others being like PKR, CSH, and SE63 genes that are more associated with the polycystic liver disease and the kidney cyst.
Okay, right. And just
what Professor Sakhuja is asking, that possibly even if you do PKD1 and 2, you will have almost 6 to 8% of people who will not fall.
Which are,
yeah,
many,
yes.
140 genes are identified. A lot of genes are there. From one family, two family, a person can fit in that. And generally, these are slow progressors, generally, these genes. And keep in mind, there is a biallelic presentation also, which is called VEO, very early onset. That is in infancy.
Yes.
Because normally you're saying a single gene, but that is a biallelic. So 2 genes are affected, and there the presentation is less than 1 year in ADPKD. And as you said, possibly, sir, the figure is that approximately 50% people go, the Western data is 50% people go to end-stage kidney failure and 50% escape. I am not sure about the age in Indian scenario. that what we are saying, the age of 70 for PKD2, 70 plus and 50 plus in PKD1. Possibly, I have got a feeling that Indians are possibly maybe 10, 12 years earlier than that.
Earlier, yes. Yes, I think all of us have seen patients in the 40s who have gone on to CKD5. So not uncommon. And sometimes even in the late 30s. So this can certainly happen a lot. One more question to Dr. Mayur, a very basic question. You know of any other way of classifying polycystic diseases of the kidneys?
Sir, we can classify the cystic kidney disease as like genetic and non-genetic. Overall, sir, cystic kidney disease?
Yeah, overall.
Overall, sir, then we can classify them as the non-genetic and genetic causes. In genetic, we have the autosomal dominant diseases like autosomal polycystic kidney disease, autosomal dominant tubular interstitial kidney disease, von Hippel disease, and tuberous sclerosis. In autosomal recessive, we have autosomal recessive polycystic kidney disease, nephronophthisis, and Meckel-Grubler syndrome. And in case of non-genetic causes, there can be a developmental like renal medullary dysplastic kidneys, and in case of acquired, we have medullary sponge kidney in case of developmental, and in acquired we have simple cyst, acquired cystic kidney disease in case of chronic kidney disease population.
Yeah. So this is the classification I wanted you to talk about. So I think all the students should be aware of this. Is a very old classification. So into genetic and non-genetic varieties of cystic disease. These cysts in ADPKD arise from which part of the nephron?
These cysts are basically arises from the initially there was a thought that these cysts were arises from all the parts of nephron, but as the studies evolved, they are more likely to evolve from the distal connecting tubules and the collecting ducts.
No, but they can arise from any
From
part
all
of the
nephron.
I don't think you should. It's not true that they arise from only one particular segment of the nephron. They can arise from any part of the nephron. That is the basic thing that you should remember.
Yes.
And what percentage of nephrons should become cystic in patients who have advanced renal failure?
In case of ADPKD, less than 5% of the nephrons are basically have cystic transformation.
Yeah, in fact, the figure that I read was only 2%.
1 to 2%.
2%, yes. So, and as you mentioned earlier, also most of these cysts lose their communication with the tubule of their origin. That's another important thing to remember. Yes, so I think these were some other important. And yes, one more point. Is the risk of malignancy increased in patients with ADPKD?
No, sir. Risk of malignancy is not different than in case of general population.
Yes, that is true. Although I would like to emphasize that I have seen maybe in so many years, I have seen maybe half a dozen cases of renal cell carcinoma associated with ADPKD. However, the statistics clearly indicate that the risk of malignancy is not increased in ADPKD. What kind of liver disease do you get in patients with autosomal recessive polycystic kidney disease?
So in autosomal recessive polycystic kidney disease, there is a affection of the bile ductule. So it will lead to hepatic fibrosis, congenital hepatic fibrosis, and also portal fibrosis.
Yeah, so that will present with portal hypertension,
yeah.
Congenital hepatic fibrosis. Yes, that is the kind of liver disease that you get in ARPKD.
ADPKD.
Yes, right. And where is the abnormal gene in case of ARPKD?
Sir, it is in the PKSD1 gene, the PKSD1, and that will lead into formation of fibrocystin polydectin complex.
Yeah, but which chromosome?
Sir, I don't.
Chromosome 6. 6. Whereas for PKD1 and PKD2, it's chromosome 16 and 4. So for ARPKD, it's chromosome 6.
I think.
I think we should be
If
calling it a day. It's been almost about near 8 o'clock. I think there is one question from the audience, and that is about the specific criteria for size of cyst in MRI for it to be significant. Mayur, you have these on MRI criteria. What do you think?
Sir, so as sir also mentioned, these are extrapolated from the studies. So in case of confirmation for ADPKD, in case of 16 to 40 years, if more than 10 cysts are there, so it is predictive value.
Size is 2 millimeter.
Size is 2 millimeter. Sorry.
2 millimeter, because the MRI is picking up to 2 millimeter.
2 millimeters.
Whereas ultrasound may pick 1 centimeter.
1 centimeter. Yes.
Yeah. One more question. What is the general term that is used to pathogenetically describe these cystic disorders?
Sir, ciliopathies?
Yeah, ciliopathy. That's the generic term that you should remember, because
basic
both,
defect is in the cilia.
yeah, both polycystin 1 and polycystin 2 have a connection with the cilia. So therefore, just like you use the term podocytopathy for patients with minimal change and FSGS, so the term ciliopathy is used to describe the cystic kidney diseases.
So I think maybe we should sort of come to a close, and I must say that it has been really a masterclass in the sense that I've learned quite a bit new knowledge from both General Varma, and as usual, Dr. Sakhuja always amazes me with his amount of knowledge and the reading that he has been doing. But that's been the case for last 50 years almost. I know Dr. Sakhuja. So that's always been like this. And I am sure that many of the people who attended today would agree with me that some of the questions that you and I face day to day in the clinic itself, the patients coming, do they want genetic testing? Should the son be told about it? And all these questions have been discussed. And I'm sure we became wiser. I'm sure our practice will become a bit relatively more confident of answering some of the questions that the patients put to us. And with the amount of increasing knowledge that is coming with some of these newer drugs that are available for our patients, we should be able to manage patients of autosomal dominant polycystic kidney disease well. I must thank Mayur for being an excellent presenter, did very well. And I'm glad that he was able to answer Dr. Sakhuja's questions, which most of the time I feel many students are not able to answer. But I hope Dr. Sakhuja, he came up to your expectations quite well.
Surely.
He could answer ciliopathy.
So I think
He could also answer ADPKD.
Yeah. I think it's been well read, and I'm glad that he's done well. So congratulations.
If you can give 1 minute, if there is any panelist who wants to, because there are all the faculty also is given the link. So if any faculty wants to ask any question.
Or any comment? Any comment? Are there other faculty members? Dr. Sanjay Agarwal was there, but I think we
have answered his question.
Yeah. I know he had asked the question, and then you may have.
Fine.
Okay. If there is none, then I must thank Micro for providing us, Raja and Deepak for providing us the logistic support for carrying on this Regain masterclass. And as usual, I would thank Professor Sakhuja, and on behalf of General Varma and myself, I would thank all of you to have come and participated in this. And I hope you enjoyed it as much as we enjoyed doing it. And we will, another 2 weeks, we will join
diabetic nephropathy.
Diabetic nephropathy, and I think it will be another 2 weeks. So we should be back again. Thank you, Mayur, and thank you, Mr. Raja and Deepak. Thank you very much. Good night. Bye-bye.
Good night.
Thank you very much.
Thank you, sir.
Thank you.
Thank you so much, sir, Vinay sir and Vijay sir.
Thank you.